added a couple that I thought were appropriate. So this is kind of what we got. So I hear you guys have really had some really incredible visuals during this course and little squeamish and stuff. I got a little bit of that, not too much today. So, all right. Basically, postpartum phase is often referred to as the fourth stage of labor, and you really should think about it like that. There are 3 distinct but very continuous periods, and they kind of overlap depending upon the patient. The initial phase, which is the puerperium, is the first 6 to 12 hours. Most literature takes it out to 24 hours. But anyway, it's the first 6 to 24 hours after the infant has left the mother's body. Rapid changes with potential for rapid crisis. So that's why, we'll talk a little bit as I get into it about some of the alternative birthing methods, but that's why I prefer in our first world nation to deliver with the best health care possible, available at a moment's notice. Subacute phase, 2 to 6 weeks, still major changes to the body. The patient at this point can often self-identify problems. I'm having headaches, my feet are swelling, so that's good. Usually, you guys know the postpartum visit is usually at 6 weeks. How many people here have kids, have given birth themselves? Okay. Don't do like I did, because, you know, when I was a PA student, I thought, psh, I've got kids, psh, I've had babies. You know, you still got to look at it from a PA student point of view. Although it's very nice to be able to apply your own experiences, I realized putting this together that I was at huge risk for a lot of stuff that no one ever even told me. So, you know, that was kind of interesting. The delayed postpartum phase lasts up to 6 months. Gradual changes. At this point, pathology is kind of rare. Usually there's not much going on except the woman being angry that she still can't get into her jeans and stuff like that. Couple of definitions. Pardon me. Couple of definitions. Postpartum refers to the person who bore the child. Postnatal refers to the infant. So don't get those words mixed up. The initial 6 to 12, the puerperium, the immediate phase, 6 to 12 to 24 hours, changes include the uterus involutes, which means that it basically contracts, it gets back to, within 24 hours after delivery, it's about the size of a 20-week pregnancy. So it's down past your umbilicus, right about your umbilicus, not too much further than that. The involution occurs as a result of the decrease in the myometrial cell size because they've been really stretched. Withdrawal of the steroid sex hormone stimulates the increased activity of the uterine collagenase. I think I said that right. If not, just don't, do Google pronounce or something. That's what I do. But basically, there's a lot of proteolytic enzymes and things that all work on the muscles of the uterus to help it to involute incredibly fast, considering how long it took to stretch to that point. Also, macrophages migrate into the endometrium and the myometrium, which helps do an incredible amount of preventing disease and infection. Because if you think about it, it's a pretty messy process, and the fact that not every single woman that bears a child gets an infection is pretty amazing and a testament to the way the body reacts. Further, the involution is further aided by manual external massage. That's where the postpartum nurse, the recovery nurse, comes about every 15 minutes and reaches in and just grabs your uterus from the outside and squeezes it and rubs it, and you're like, oh, stop, oh, dear God, stop. But yeah, because there are contractions that feel a lot like your labor contractions, only not quite that bad. And by now, all your drugs have worn off and everything. So these contractions after childbirth are called after pains. And you can have them even while you're nursing, because your your posterior pituitary gland releases oxytocin while you're nursing, and that also helps to cause the uterus to contract and involute. Sometimes the after pains can last a little longer than 24 hours, but that's with multiple. Usually with the first child, they're gone after 24 hours, but the more kids you have, the longer they can stick around. This is the fetal side of the placenta. You can see it's really nice and well vascularized, and if you look up in the corner here, you can kind of see a 3-vessel cord right there. Can you guys see that? Can you see my mouse on there?
No. If you drag it to the right or left.
Just drag it to the side of the screen.
Just do what?
If you just move it to the complete side of the screen and then keep going.
Okay.
And if that doesn't work, try the other side. Right there. Now look up here and we can see.
Now I'm supposed to try to find it?
You'll watch it up there.
Can you? Okay, well the point is, can you see the cord?
Yes.
Okay, that's pretty obvious, right? Can you see, if you look up there right at the top, you can see that it's a 3-vessel cord.
Yes.
Can you see that? I thought that was interesting. Okay, where the placenta implants in the wall of, in the interior of the cervix, the wall of the endometrium, within 24 hours after childbirth, that site contracts to about half the size that it was before, which I think is just amazing. And what that does is that sudden contraction, what's it going to do? It's going to shut off the blood flow, okay, so that the blood doesn't continue to go into the uterus, because the placenta's out now, and otherwise it just goes and then continues to drain out. Regeneration, endometrial regeneration, so the inside, basically when you've had a baby and you've lost the placenta, you've lost all the lining to the endometrius, so it regenerates by about 3 weeks, okay, and then, but the placental implantation site doesn't regenerate because that's where the most changes to the endometrium occur. It doesn't regenerate until about 6 weeks postpartum. This regeneration is the cause of the lochia that women have, the discharge that women have after childbirth. Have you guys heard the term lochia? Okay, well, I'm going to talk about it anyway. This is the maternal side of the placenta, so you can see that it's kind of gross, but that's what's stuck up against the wall of the cervix. Anybody familiar with the Lotus birth? While I was doing this presentation and doing some of my research, I found this. You're nodding your head?
Yeah.
You've heard of it? Oh, okay. Well, anyway, there's a theory in India. It started out of India that if you keep the baby attached to the placenta until the cord naturally dries up and falls off, that the baby has less of a shock into this world, and that it actually gets some good from that. I like the looks on your faces, because that's exactly how I felt when I saw this. But evidently the placenta, they keep it for like up to 6 days outside the baby, and they like wrap it up and put salt and lavender and stuff on it so it doesn't stink, and keep it in ice. And I like this person that went down to the Family Dollar and bought the colander for a buck to put it in. And then done that for some reason, I don't want anything that looks like that close to my beautiful little newborn baby. So, but I swear, if you go into women's health and practicing women's health, there are going to be people that want to do all these different kind of things. And I know that Dr. Armstrong feels very strongly that, well, then you're just not going to be my patient. And basically, people have, the trend in the last 15 years, 20 years has been to really kind of direct your childbirth, you know, and you kind of call the shots. But the smart OBs don't go for that because they're the experts and the parents are not. Now, it's great to have a birth plan. If I can, this is what I would like to happen, but really in the grand scheme of things, I think it's wisest if the mother understands that she needs to defer to the expertise of her OB. When I was working at Moore Medical Center doing pediatrics, there was an OB that have privileges and more that the mom and baby died during childbirth because he let her stick to her plan too long. And that just always kind of hit me hard. Okay, so you guys have already talked about lochia, but I'm going to talk about it again. The first 3 to 4 days, you've got the lochia rubra, which kind of looks like a regular menstrual cycle. It's bright, heavy, bright red, sometimes with clots and things. Then it turns into, after about 10 days or so, after 6 days or so, it turns into the brownish red, which is lochia serosa, and this is all because of the healing of the inside of the cervix, the endometrium, is what's causing this discharge. And then the lochia alba, which is can last up to 4 to 5, sometimes 6 weeks, yellowish. The thing is, this should never get stinky. So, I mean, it's just normal. I mean, yes, go ahead.
Oh, I was just wondering if this is different between vaginal versus cesarean delivery.
No, you're still going to have that lochia.
Okay.
Yeah, still going to have it because you still got to get rid of that. Hang on a second. Derailed there, locomotive derailed. Anyway, but it stays around for about 5 to 6 weeks or so. And one of the things you warn your patients at discharge is if it gets really foul smelling. I mean, it's not real pleasant, but if it gets super foul smelling, give the office a call. Postpartum hemorrhage. That's defined as excessive bleeding, which most sources define as greater than a half a liter, 500 milliliters, in a vaginal delivery. Even though, if you really get technical about it and measure the blood loss in a normal vaginal delivery, it's about 700 milliliters. But if somebody in the room calls postpartum hemorrhage, everybody's going to follow this guidelines, even though someone's standing there going, nope, we've only got 650, nope, we've only got 450 milliliters, no, we're still going to be a postpartum hemorrhage. Early postpartum hemorrhages happen in the first 24 hours. Late postpartum hemorrhages happen 24 hours to up to 6 weeks postpartum. Major causes of postpartum hemorrhages, urine atony, in about atomy, however you want to say that, 50% of cases. So basically this can happen because of excessive manipulation of the uterus. General anesthesia is a contributing factor to atomy. Uterine overdistension, such as twins or polyhydramnios. Prolonged labor, which is, what's the definition of prolonged labor? Greater than 24 hours. 24 hours after, prolonged rupture of the membrane is greater than 24 hours. Prolonged labor is, greater than, I don't know what mom feels like she can stand. Oxytocin induction, so anybody with a pit drip going to keep their labor going is at risk for postpartum hemorrhage. Intrinsic biometrial dysfunction, so the inside, the endometrium is just not working like it should be. It didn't clamp down like it should have. And then grand multiparity. Does anybody know what grand multiparity means?
Lots of babies.
Huh?
Lots of babies.
I like multiples.
Yeah, actually greater than 5 live births is grand multiparity. Here's a picture of urine atony. You can see that the hemorrhage is coming from the source of the implantation of the placenta. And the bottom picture is kind of interesting because this is a pretty common thing to do that manipulation there, or that massage. You actually are holding pressure. I know it's kind of a little graphic, but you're actually holding pressure on the bleeding site. So think about that like just holding pressure on a wound. And that's essentially what they're doing. And at this point, that's the first thing that you're going to do to try to stop postpartum hemorrhage, an early postpartum hemorrhage, is just hold pressure. That works in a great number of cases. If you need to use medications, you can start a little low-dose pit or a methadone. So another cause of postpartum hemorrhage in about 20% of the cases, as opposed to the atony, which is the majority of the cases, is obstetric lacerations. The lacerations can come from the episiotomy, they can come from an uncontrolled delivery. Do you know what an operative delivery is? Not just a C-section, but that's any time they have to use any external manipulation. Forceps, vacuum suctioning, those are called operative deliveries, okay? An uncontrolled delivery is where it's just too fast and it wasn't well controlled and well managed. And the lacerations can involve the uterus, the cervix, the vagina, or the vulva. And when vessels are lacerated underneath the vagina or the vulvar epithelium, there's often hematomas. So if you see a hematoma in the vaginal wall after delivery, it needs to be lanced to allow it to drain to ensure that there's not an active hemorrhage at that point. A lot of times the hematoma lacerations that don't actually, they're submucosal, they're deep lacerations, not actually into the vaginal wall. They're not even noticed until the patient goes into shock. Obstetric lacerations, persistent bleeding, I thought this was just really important to be included. Persistent bleeding, especially bright red and a well-contracted firm uterus, suggests bleeding from a laceration or from the episiotomy. When cervical or vaginal lacerations are identified as the source of postpartum hemorrhage, repair is best performed with adequate anesthesia, okay? These don't necessarily have to go to the OR or go to the OR to be repaired. They can be repaired in the room. Spontaneous rupture of the uterus is extremely rare. Risk factors for this complication include grand multiparity, a malpresentation. What's a malpresentation? Breach, or a frank breach, full, a complete breach, a foot presentation. What's that called? A footling. Previous uterine surgery. So what does that sound like? Previous C-section, that's exactly right. And also oxytocin-induced labor. Now that's not the same as an oxytocin-assisted labor. That's not as great a risk for uterine spontaneous rupture of the uterus. A woman comes in labor, it kind of slows down, and they use oxytocin to augment it and keep it going. That's different than if they come in and say, oh, well, it's March 14th, I really want to have my baby by the 15th, so let's do this today, and they start a pit drip. And that's kind of the thing. Let's see, rupture of a previous cesarean section scar after vaginal delivery is an increasingly important cause of postpartum hemorrhage. Because, why? They're called VBAG, vaginal delivery after C-section, are becoming very popular. And some OBs are allowing it, and some OBs are absolutely not. They're not willing to risk that, because it is a huge risk. Retained placental tissue accounts for maybe 5 to 10% of postpartum hemorrhages, especially associated with placental accreta. Does anybody know what that, you guys heard that word before?
Yeah.
Okay.
It's like embedded in the membrane.
That's exactly right. If I could see that far, it would really help, but that's why, because I really can't see that unless I get up there just like redonkulously close. Anyway, so, or if there's a manual removal of the placenta, okay, or mismanagement of the third stage of labor, you let it progress too fast. Unrecognized succenturiate placenta. Do you know what that is? That's a succenturiate placenta is, you'll also hear it called a lobed placenta. That's where the placenta doesn't develop as that one nice smooth thing that I showed you. I always thought of the placenta as kind of like the liver. To me it just looked like a liver. But anyway, it doesn't develop like that nice smooth thing. It'll have an arching vessel and then a complete other lobe over on this side. And often, if they mismanage the third phase of labor and they kind of pull a little bit, it can sever that vessel. rather than giving it time for that placenta to completely detach from that wall up there. And also, of course, if the mother has a history of any kind of coagulation defects. So those obviously are a contributing factor to a postpartum hemorrhage. Let's talk a little bit more about accreta, okay? The placenta, her accreta is through the uterine wall, and it's associated with previous cesarean delivery. It's especially, just the placenta accreta is the term for any kind of invasion of the placenta into the endometrium wall. That's the general term. And it just gets too deeply into the wall. It's diagnosed by ultrasound and then affirmed and defined as to how deep it is by MRI. Here's a picture of the different types of accreta, but if it's just accreta, that's the general term, but then you've also got increta, where it goes well into the muscle wall, and then percreta, where it goes through the muscle wall. And you can see the difference between the normal and the accreta. It's just, you still see that nice defined endometrium, but then it's just going too deep, and that's going to be a huge risk factor for, although not very common, it's a huge risk factor for postpartum hemorrhages. Uterine inversion as opposed to involution, sorry guys. Inversion as opposed to involution is where the uterus just kind of follows that baby right on out, or follows that placenta right on out. So you can see the Foley catheter tube there, okay? There's degrees of this. This is why they got to check. There's degrees of this. It can just like, because the uterus is like this kind of dome-shaped thing, if it just kind of dips down in the top, that's a first degree. It's just kind of dimpling a little bit. It's still got to be fixed, but that's a first degree inversion. And then if it comes out into the vagina, through the cervix into the vagina, that's a second degree. And then the third degree is where it's visible outside the vulva. So what would you call this one?
Third.
Yeah, very good. And you can see the reduction. This is basically they reduce it just by pushing it back up in there gently. Not fingers. You can't use anything sharp because then you're at risk for rupture. That's exactly right. Any questions about that? Here's another picture. Oh no, here we're moving on to laceration, sorry. So have you guys talked about lacerations? Okay, so you know the difference, first, second, and third degree lacerations? Okay, well I won't go into too much detail then about that. But the trick to repairing the laceration, I'd be really surprised if you guys ever repair a laceration, but if you do, be sure and write a really awesome procedure note in Typhon about it, because I want to hear about it, because I think that's really cool that your provider trusted you to do that. Begin the repair above the laceration, because often those torn vessels will retract up into the tissue, and then just kind of suture it on out. You got to bring a little traction to bring the you use a little traction to bring that laceration site closer to the introitus so that you can see what you're doing. Okay. Any questions about anything so far? I'm going a lot faster. I probably could have started at 9, sorry. But yeah.
I have another C-section question.
Yeah.
I mean, obviously they pull the baby out, but what do you do with the placenta? Because naturally, when you give vaginal birth, then it kind of comes off and comes out. Does that happen when you do C-section, or do they have to take it off?
No, it doesn't come out vaginally at all. It still comes out through the...
But do they wait for it to come off, or do they...
It will naturally detach. That's exactly right. It will naturally detach, and then it's just scooped out. I got to, during my student phase I was at, and I'm working on this rotation site for you guys, by the way. I was with Jean Olivia Grant down at Choctaw Nation Hospital in Tallahena, and her PA, Dr. Grant has retired, but her PA that I was with is still practicing, so I'm like, hey, Mary. But anyway, so I actually got to catch 3 babies on my own, with Mary just like right here, breathing heavy over my shoulder, and me going, oh my God, that's slippery. And then I actually got to go into an emergency it was a scheduled C-section with Dr. Grant. Emergency C-sections, they ain't got time for squat. But a scheduled C-section, I got to do one with Dr. Grant. And yeah, that was so cool. I mean, I think I'm pretty sure I was crying under my mask, you know, and everything. And it was just like, and I'm like, oh my God, how do you not cut? Because I don't know about you, but even pinning a baby's diapers, you guys probably don't even know what that is, but you stick your fingers underneath it. Okay, zipping up your kid's onesie. You might remember this. You put your finger underneath behind the zipper and you pull it up so it doesn't pitch the skin. I put my fingers behind the diaper and before I put the pin in, and I'm like, where's your finger to make sure you don't cut anything? So, but anyway, they obviously can't do that, but that's what I was thinking as I was crying. Okay, so yes, they wait for it to naturally detach and then lift it out.
What causes it? I mean, is it like the baby breathing oxygen or something? Like how, what?
It's just the miracle of childbirth. If I really honestly don't know, and I'm not going to try to BS you. So, I mean, that's the one thing I won't do is try to BS you. All right, no questions? We'll get off this ugly picture. Episiotomy care. I saw that cartoon up there, the lady in the tub. That is totally true, totally true. You can do that, it's called a sitz bath. You'll hear that phrase. Some people just do it with warm water. Some people put a little Dreft laundry soap in there, kind of just as a cleaning agent. And you can see the bottle and the perineal area. You know, you got to keep it clean. If you think about it, how yucky that part is, the fact that we don't have more infections and episiotomies and lacerations repairs is kind of amazing. You can use dry heat, 20 minutes, 3 times a day can be really super helpful. That can be done with a hair dryer. Sometimes in the hospital they might do a heat lamp. Immediately after, they're going to put an ice pack on your perineum to kind of help with the swelling and stuff right there. And the sutures don't have to be removed, thank God, because there's already been enough business going on down there. You're tired of everybody, you know, in your business. Any questions about any of that? Okay. Endometritis. This is an infection of the endometrium, which, like I said, is surprising doesn't happen more often. But you're looking. You guys, they're going to talk. You guys are probably different. You might think more Celsius than I do, but you just got to remember, 38 degrees is 100.4. Okay, and basically anything above 38 degrees Celsius, they kind of consider a postpartum fever. Okay, so you're watching for that. Happens on a couple of different occasions, 24 hours apart. Not just, you know, I took my temperature at 1 and at 1:30. You know, so. After delivery, okay? They cause 7% of postpartum fatalities in the United States every year. So it's not something that you want to ignore. It's not common, but it does not need to be ignored. It's associated with prolonged rupture of the membranes, PROM. This brings up a point about acronyms in healthcare. What do you guys usually think of when you see PROM? Passive range of motion. So you got to know, it's like take everything in context. You know, if you're reading a lady's chart that just gave birth, it's probably prolonged rupture of membranes. You know, so toxemia associated with endometritis, intrauterine pressure catheters, especially if they're in there a long time. Fetal scalp monitoring. I mean, think about this. This is just, even though that fetal scalp monitor came out of a sterile bag, you know, this is just different ways of introducing bacteria into the interior of the cervix. I mean, of the uterus. Excessive number of digital vaginal manipulations. This is why, as much as you want to check to see the progress every 30 minutes, this is why a seasoned L&D nurse will say, no, we need to wait a little bit, because they know that's an increased risk of endometritis. Or coitus near term, even though old wives' tale will tell you that'll cause a late. If you're overdue, never mind, I'll a shot. Fever, so they're going to have fever, they're going to have soft, tender uterus, okay? Here's another cup. Just remember, 38 to 40 degrees Celsius is 100.4 to 104. So that's easy to remember, 38 to 40, 100.4 to 104, okay? Usually develops maybe the second or third day postpartum. Early fever within hours, this is important, early fever within hours of delivery and hypotension are nearly pathognomonic for infection with group B strep. You guys have talked about group B strep? Okay, we'll talk about it a lot more in peds. Okay, any questions about endometritis? All right, I really should have started this really about 9:15. Okay, so postpartum depression. Depression that begins in the 12 months after delivery. And we're going to talk about this in pediatrics too, because you can't take care of the baby if the mom's not taking care of herself. Mom can't take care of a baby if she can't take care of herself. Basically, criteria for diagnosis are the same as in a non-pregnant person, a non-pregnant related depression. And symptoms need to be present every day for the majority of at least 2 weeks, nearly every day. Derangements in sleep patterns. Okay, now I thought that was a little ridiculous. Anybody's ever had a newborn knows your sleep pattern is completely deranged. Changes in energy level, another thing I thought was a little ridiculous. Changes in appetite, weight changes. Who's not losing weight after they give birth? Oh, I don't know, me? No, I'm just kidding. And changes in libido. Yeah, so those aren't real good. The really good thing is the Edinburgh postnatal depression scale, and we give that. In pediatrics, you should give that to your parent. You can give that to your mom. Most of them give it at the 1 month visit. That's a pretty routine part of a 1 month visit. During pediatrics, we'll talk about that. I'll have a handout for you about the post-depression scale. Okay, postnatal depression scale. Did anybody, I mean, that was kind of funny because I always wondered about the title of that, because the mom's postpartum, the baby's postnatal, but they're checking the mom's depression, so I don't know, it's all tied into one, so I always thought that was misnamed, quite frankly. I just threw these slides in this morning because I really wanted you guys to know this, and especially with the uncomplicated, or the complicated delivery. So basically, eclampsia can still happen after the baby's out, okay? Even if they didn't have preeclampsia, even if they didn't have any gestational diabetes, they can still have eclampsia after the baby's born, up to 6 months, okay? And I'm saying this mainly because you guys, a lot of you guys might go into emergency medicine or urgent care. You're going to see it urgent care. You're going to see this at urgent care probably more likely than the ER. If it presents to the ER, it's going to be obvious because she's seizing. But basically, in the, you're going to see this more in just urgent med. The risk factors for preeclampsia and eclampsia. If they've had any kind of previous preeclampsia, if they've got a family member with preeclampsia, they've got aunts or sisters that had eclampsia, or their mom did, any kind of pre-existing renal disease, obesity, they're greater than advanced maternal age, in this case it's 40. If they had more than 10 years in between their pregnancies, you know that if it's been more than 5 years since you had a baby and you're having another one, it's like your first one all over again. Yeah, I know, it's kind of sad, but your body's like, okay, I forgot what we're doing here, and it goes back to like the first time. The blood pressure, initial systolic blood pressure greater than 130 or diastolic greater than 80 during the current pregnancy puts them at a greater risk for postpartum eclampsia. Here's the way it presents: a headache. That is the most common presenting symptom. A mom with a 3-week-old, and it's not, sometimes it's pretty obvious because they come in carrying that kid, but otherwise this is going to rely on your very skillful history taking. You know, they might not even think about it because they're onto something else. They think they've got a virus. They think they're coming down with the flu. You'll get a lot of moms coming into urgent care with a baby at home because they're afraid they're going to get the flu and they want to get on Tamiflu so they don't get the baby sick. They have hyperreflexive reflexes, hyperactive reflexes, you know that. And then they can have hypertension, sometimes as insignificant as 140/90. I mean, that's not even really a treatable hypertension, but that can certainly be a symptom of postpartum eclampsia. Proteinuria, need to check a urine in every postpartum female that complains of a headache. Visual changes, epigastric pain, pitting edema in the feet, all of those are clinical presentations. Okay, so any questions about anything? I could have started at 9:30. Any questions about anything so far? Yes?
Can't moms who get like an epidural get a headache after their epidural?
Yes, that is true. That is true. That's not, that, you're right. They can get an epidural headache. Good recovery room nurse will keep that mom as flat as possible to really negate the possibility of that. But we're talking a mom that's a week out.
Okay.
She's not going to have an epidural headache a week out. Okay?
I've had a spinal headache from that epidural. It happens within a day.
Yes.
It is horrific.
Yes.
And it is positional. The
Yes.
headache goes away when you lay down.
Yep.
It's a spinal headache.
Yes.
I mean, I had to nurse my child for 3 days just laying.
It really isn't a bad thing.
The worst
if you
thing
think
you've
about
ever
it.
had in your life. The headache goes away when they lay down. It's from the spinal.
Okay, all right, so we're ready to discharge our postpartum patient. Okay, we'll talk about discharging the infant in peds, but this is discharging the postpartum patient. You're on your OB-GYN rotation, and you know that she's going to go home. You do your discharge physical exam before your preceptor gets there, and you will be a rock star, especially if you do it properly. Check the breasts and abdomen, because what are we checking for on the abdomen? We're checking for tenderness of the uterus, okay, and we're checking for fundal height. We're making sure it's continuing to drop down. Degree of uterine involution should be noted, which is what I just said, the fundal height. Calves and thighs should be palpated for thromboembolism, thrombophlebitis. That's a real thing, guys. I mean, I've actually felt those cords, you know. I mean, it's a real thing. It's kind of crazy. Also, you're checking for pitting edema, remember? And then if they've had an episiotomy or any kind of laceration, you need to go take one last look and make sure everything's okay. You're looking for redness, signs of infection. And then discharge instructions depend on a lot of things. On the next page, we'll talk more about that. But are they breastfeeding or not breastfeeding? So if they're breastfeeding, discharge instructions include put the baby to the breast at least every 2 hours. Don't let your nipples get cracked and sore. If they're having any trouble whatsoever, don't be afraid to ask for a lactation consult. A lot of times they can come back. I know Lakeside has some great, Integris has a great lactation consult. They can come back in and talk with lactation just at their convenience in the next day or so. And a lot of times they'll, watch them breastfeed. If they're not breastfeeding, you can recommend binding the chest. Can really help to just kind of, the mammary gland. It's an exocrine gland, so binding the chest. Antihistamines can really help to decrease that milk production. So if they can tolerate Benadryl or maybe Claritin or Zyrtec, I know it sounds silly, but it can really make a difference. The one thing that you want to tell them not to do is when they're to the point where they're ready to just cut them both off, don't go stand in the shower and let the milk drain, because it will just make more. Because it's the same principle when you're nursing your baby. The more they nurse, the more you make. That's why you got to put them to the breast every couple hours. If they take the pressure off, they're just starting all over again. So recommend that they just and they used to do some medication. Back in my day, although I breastfed all my kids, back in my day they would offer medication to dry you up, and they determined that was actually more harmful than helpful. So now we just say antihistamines. More discharge instructions. uterine changes, tell them about the cramping, if they're what was that word, a grand multi? That just cracked me up. Anyway, if they're one of those, they can feel those after pains when they nurse for 5, 6, 7 days. The grander of a multi-parity they are, the longer they're going to feel those after pains. Talk to them about vaginal discharge. The lochia, prepare them for the bright red and then the brownish red and then the whitish lasting for seemingly ever. Usually you're over it by the time you go to your postpartum checkup, but talk to them about that. Talk to them about episiotomy care, recommend the sitz bath, keeping it clean. Your squirt bottle should be always with you when you go to the bathroom. Pain relief at this point is usually, unless there was something hairy, pain relief at this point is usually Tylenol number 3s or just Tylenol. Okay, there's not a lot of, it's amazing how quickly your body returns. Diet nutrition is going to be different whether they're breastfeeding or not breastfeeding. They need to continue their prenatal vitamins for at least until they go to their postpartum, their 6-week checkup. If they're breastfeeding, continue the prenatals as long as they're breastfeeding. And then remind them to call their doctor's office in a few days to schedule their 6-week visit. Whenever you're discharging a patient from the urgent care, your family practice office, the hospital, you always tell them when to seek help, when to seek more medical attention. Because a lot of times, oh, well, I was just in the hospital, so everything's fine. No, tell them to call the office or, go back to the, most of the time, they're having a problem, they just go back to L&D. They don't have to present to the emergency room of the hospital where they delivered. They can just go back up to the L&D floor, especially if they're having a fever greater than 101, which is about 38.6, 38.8. See, you just kind of, do the guessy thing, but it works. Foul smelling. If their lochia gets foul smelling, or it irritates them, okay, or it's itchy or something like that. If they have gotten to all the lochia part and suddenly it's bright red again, well, that might be an indication that something's going on. Oh, I just said that. The leg. Warn them about swollen, painful red areas on their legs. That can indicate a thrombophlebitis. Burning sensation during urination or an inability to urinate. Urinary retention can sometimes be a postpartum problem, as can constipation. You really got to get them started on a stool softener, just pretty much right from the get-go. If they have any sudden sharp pains in the vaginal or the rectal area, the crying or periods of sadness beyond 2 weeks, we're warning them about postpartum depression. Or if they have a C-section incision that is red or draining or painful, then you go call the doctor. All right, these are my references. In case you're interested, you can always read more about it. Currents is available online. The Journal of Prenatal Medicine is available online. You just search for it. And then the Merck manual is just something I think you guys should have. I think you can download a free PDF of it, but it's just an excellent reference, okay? It really is. I mean, I don't know about you, Professor Rourke, but I studied currents during my didactic and Merck and Harrison's during my clinical, because Merck just puts it in like real language. I'm communicating with my patient, here's real language. So.
Get you out of the weeds.
Yep, get you out of the weeds. And this was chapter 254. That tells you a little bit. I should have started at 9:30. Okay.
I think Dr. Latassi is ready to go.
Yeah, you guys want to take a 10-minute break and I'll get Latassi down.